Thank you. Thank you and good morning. Welcome to World Prematurity Day and to this national conference on prematurity prevention. The beautiful purple images that you see are a reminder to all of us that premature birth affects millions of families all over the world. And these lightings across our country and many, many places across the world are made possible mostly by parents. Groups of parents who have rallied together to raise awareness that premature birth and its many complications are now the leading cause of 0 to 5 death in the world. We know, because we're here today, that prematurity affects every community. It affects Black, it affects white, it affects Hispanic, it affects Asian, it affects the rich, it affects the poor, it affects babies who are born on dirt floors in African villages, it affects babies born just across the river at Children's National Medical Center. Today, on World Prematurity Day, we're convened as national health leaders in the United States, but we're also part of a greater global movement now to combat premature birth. I think all of you know that our nation has one of the highest rates of preterm birth of any industrialized country. And we're here because we believe that we can and we must do better. Premature birth takes the lives of babies. It changes forever the lives of parents. It causes disabilities. It strains our educational system, our rehabilitation system, and our health system. It drives up healthcare costs for everyone, from individuals to business to government. It was really for all of these reasons in 2003 that the March of Dimes launched a national prematurity prevention campaign focused on reinvigorating scientific discovery and a call to action to redouble our efforts to prevent. We set 2 goals in 2003. Number 1, to raise awareness in our nation that premature birth was common, costly, and serious in its health consequences. We also set at that time what seemed to be a nearly impossible goal, which was to reduce the rate of preterm birth by 2020 to 9.6%. We're very proud and we're very grateful that we were joined at that time in the campaign by our partners, by our stalwart and faithful partners, the American College of Obstetricians and Gynecologists, the American Academy of Pediatrics, the Association of Women's Health Obstetric and Neonatal Nurses, and by ASTO, the Association of State Territorial Health Officers, AMCHIP, the Maternal and Child Health Professionals, and NACHO, the local city and county health officials, really reflecting a broad and committed and visionary leadership in the health community. And we were also joined by corporate thought leaders such as Johnson & Johnson, FedEx, and Cigna, and many more, who understood very early on the consequences of premature birth to the business community. As the campaign moved forward, hospitals became our partners as well, implementing new extensive prenatal care outreach programs and quality improvement programs such as early elective delivery, not before 39 weeks of completed gestation, and also improving outreach and educational services for affected parents. Also moving forward, state governments signed on and accepted the challenge by the Association of State and Territorial Health Officers that was authored by Dr. David Lakey, who many of you know, to reduce the rate in states of premature birth by 8% over 5 years, and to also work toward the goal of 9.6%. And the responsibility of the March of Dimes in that challenge was to create awards, APGAR awards and FDR awards that were given to states, and many states have succeeded with APGAR awards, and some have even succeeded reaching the 9.6% goal. So working together, we brought a halt to what had been 3 decades, 30 years of steady, incremental rises in the rate of preterm birth in the United States. The rate of PTB in the U.S. peaked in 2006. And from 2006 to 2013, there was a 14% reduction overall in the rate of preterm birth in our country. And based on real improvements, based on interventions and programs and mobilization that happened all over the country, based on your leadership, in 2014, we reached the goal of 9.6% in the United States, based both on real improvement and by a one-time technical change by Centers for Disease Control in the way that prematurity was measured. About half and half contributed to reaching 9.6. It is amazing that we reached that actual number of 9.6, but I think we can all embrace numbers as our friends in this particular situation. Now, going forward, we need to continue to accelerate that change, that positive change in the rate of preterm birth. Now, we're very, very proud. We should all be very proud of the progress that we've made. But progress is not victory. Progress is not victory. And our U.S. preterm birth rate is still substantially higher than most every other high-income country in the world. And I think most notably, and very much a theme of our conference and a theme of our report cards and our efforts at March of Dimes going forward, is that this progress, notable as it's been in the U.S., has not been shared equally across communities and across racial and ethnic groups. Many cities, states, racial groups still face untenably high burdens of premature birth. So we've got to do more as a people, as a nation, at every level of government, state and local government. And we need to do more to mobilize science to discover the unknown causes of premature birth and to take those findings and translate the new understandings into advanced risk detection and intervention earlier in pregnancy and hopefully even at a preconception. So today we come together to commit ourselves to finding the best approaches, to supporting each other's work, and to commit to action going forward. Now, the March of Dimes and our 6 partners that I've mentioned earlier, we've set a new goal for 2020 for the nation. It's 8.1%. 8.1%. And we're going to share that with you today, as well as a new goal for 2030 so that we are in alignment with the United Nations goal setting, a new goal of 5.5% or better in the U.S. by 2030. This will put us in the top bracket of the high-income developed countries of the world, make us one of the best places in the world for birth outcomes. Later today, you're going to hear from our March of Dimes trustee and former U.S. Surgeon General, Dr. Regina Benjamin, who will share with you the broad outlines of our proposed roadmap for reaching these new goals, 8.1% by 2020. And through our breakout sessions, we'll get into more in-depth discussions about how to bundle, scale up, and leverage strategies and programs that are working to make a bigger impact. So I want to thank each and every one of you for bringing your considerable thought leadership, your community connections, and your experience to this conference. We must collaborate together successfully to achieve success. The gene for collaboration is not being particularly well channeled in our country today in many places. I'll mention one that's pretty near here. I could mention the U.S. Congress, but I won't. It would be impolitic of me to do that. But I will say to you, our maternal and child health community, we do know how to collaborate. We do know how to share best practice. We do know how to support each other. We do know how to make things work. And whatever our political dispositions, we know how to come together to make a better future for mothers and babies. And for that, I am profoundly thankful to each and every one of you. So thank you for your caring. Thank you for your personal commitment. Today's a very, very special day, World Prematurity Day. It's a very special day for parents all over the world and their families of premature infants as they gather to honor, to remember the babies that didn't make it, and to fight for their children's health and for the future. That you're assembled here today with the cause of premature birth in your minds, in your professional outlook, and in your hearts, truly is felt around the world. Parent groups all over the world know that you're gathered here together today to think about the future and how to accelerate positive change. So I want to thank you, and I want to wish you a very, very successful conference. Thank you very, very much. And now it's my pleasure to introduce the first panel, and particularly the moderator, although he's not always moderate, I want you to know that. He's very passionate about the cause of children and mothers. Our first panel is called Science of Prematurity, What We Know and What We Need to Know. And our moderator is Senior Vice President and Chief Medical Officer for the March of Dimes for our Office of Medicine and Health Promotion, Dr. Ed McCabe, who's known to many but not all of you in the room. Before coming to the March of Dimes, Dr. McCabe was Chair of Pediatrics and Physician-in-Chief of Mattel Children's Hospital at UCLA. He is both a pediatrician and a card-carrying geneticist. He was elected member of the Institute of Medicine and a fellow of the American Association for the Advancement of Science. He's been president of the American Board of Medical Genetics, the American College of Medical Genetics, the American Society of Human Genetics, and the American Pediatric Society. Dr. McCabe also chaired the March of Dimes Basil O'Connor Award Committee for the March of Dimes, and among his other many accomplishments, he served as chair of the U.S. Department of Health and Human Services Secretary's Advisory Committee on Genetic Testing. So, ladies and gentlemen, I introduce to you Dr. Ed McCabe. Ed?
So thank you very much, Dr. House, for the introduction. Welcome to everyone here. I'm extremely happy that you are here and to be here with you. I'm going to give you an overview of really the conference, but also the roadmap and the plans, and you'll be hearing much more about this from Dr. Benjamin at the keynote speech during lunch, and then throughout the panels where we really organize the meeting around these interventions so that we can all learn from each other and do a better job as we embark on this roadmap to 2020 and 2030. I have nothing to disclose. For social media, they gave me very specific talking points to be sure I get it right. So internet access is available in all meeting rooms. To access the internet using your wireless devices, navigate to the list of available wireless networks, connect to the Marriott Conference Network, open any browser, and go to any web page or refresher page that you already have open. The landing page will appear, and then enter the passcode MOD 2015 in the left-hand section of the page. And after reading the terms and conditions, which we all do every time, then click Agree to connect. If you want to see the slides live on your devices, then please visit prematurityprevention.org, A link can be found in the first paragraph directing you to the page, and registration is required for the site, but there is no cost. Please share what you're learning at the Prematurity Prevention Conference with your Twitter followers and the wider world using the hashtag PPC15, Prematurity Prevention Conference 15. So with that housekeeping, let's move on to the content. We owe it to the next generation of U.S. babies to prevent preventable preterm births. We must fully implement what we already know, and then we need to translate discovery research to increase the preventable preterm births. And we'll be hearing from Kathy Spong, Interim Director of NICHD, as well as Dr. Debbie Driscoll, head of one of our prematurity research conferences, and they'll be telling you about some of that exciting research that we need to translate. As Dr. House mentioned, we achieved the March of Dimes 2020 goal 7 years early. The nation met that goal of 9.6% U.S. preterm birth rate because fewer babies are being born preterm, but also fewer babies are now counted as preterm due to a change in the measurement by the CDC's National Center for Health Statistics. I'll point out that a couple of papers, including a report from the March of Dimes, points out that while fewer babies are being counted as preterm, those who are sicker. So it is a better metric that we have now for identifying preterm birth. But progress is not victory, and despite the progress, the U.S. preterm birth rate ranks very poorly among the very high Human Development Index countries. We need to do better. So the March of Dimes Board of Trustees resolution in June of this year reset the goals and maintains the urgency. As Dr. House said, 8.1% is the 2020 preterm birth rate goal for the U.S. set by our Board of Trustees, 5.5% by 2030, and the March of Dimes 2015 premature birth report card reset the 8.1% target from 9.6%. There's a new focus in our report cards on high volume and high burden areas and populations. So we need to optimize existing preventions. We will continue the prematurity campaign and launch the roadmap to 2020 and 2030 goals. We will accelerate change in 16 high burden and high volume states and territories, and we will continue our activities in all states and the District of Columbia. So the target 15 states plus Puerto Rico. Phase 1 will identify 6 states and territory in 2017. These will be Alabama, Louisiana, Mississippi, and Puerto Rico, where we have the highest rates of preterm birth in the US, and then Florida and Texas, the most populous high-rate states. Phase 2 will add 10 additional states with births greater than 100,000. These will be California, Georgia, Illinois, Michigan, New Jersey, New York, North Carolina, Ohio, Pennsylvania, and Virginia. But again, we will be continuing all activities in all states and territories as well. These are the interventions, and you'll be hearing more about these in the panels and from Dr. Benjamin. Improving birth spacing and interconception care, group prenatal care, elimination of non-medically indicated early elective deliveries, smoking cessation, access to progesterone shots for women with a previous preterm birth, low-dose aspirin to prevent preeclampsia, vaginal progesterone and cerclage for short cervix, and reduce multiple births conceived through ART. We also will be bundling interventions through the Healthy Babies Are Worth the Wait community programs in those target states and Puerto Rico. We will engage stakeholders. We're beginning that with you today, and thank you for engaging with us. We put out our premature birth report cards with an emphasis in states with high volumes, cities and counties. So really looking at opportunities where there are high volumes in these states, and then disparities among ethnic and cultural groups. Prematurity Prevention Conference today and tomorrow, Quality Improvement Evidence in Practice. Dr. Regina Benjamin, as I mentioned, former Surgeon General and March of Dimes trustee, will give the keynote address. And I also want to thank Captain Wanda Barfield and her Division of Reproductive Health at CDC for generously supporting, in part, this conference. We need to identify new treatments based on translation of discovery research. The March of Dimes investment in the prematurity research centers is essential to achieving 5.5% by 2030. The prematurity campaign has already achieved remarkable results. The preterm birth rate has decreased to 9.6 in 2014 from the peak in 12.8% in 2006, as mentioned by Dr. House. That has resulted in an estimated 231,000 fewer babies born premature from 2006 through 2013. That's a small city of babies. And with the roadmap activities, 1.3 million fewer babies will be born preterm between 2014 and 2030 when we meet the 5.5% 2030 goal. 210,000 fewer babies will be born preterm from 2014 to 2020 when we meet the 8.1% goal, and 1.1 million fewer babies will be born preterm from 2021 to 2030 when we meet the 5.5% 2030 goal. So we are making a difference. It's a huge difference. And again, we owe it to the babies in that next generation to make this difference. Our next steps, planning is underway to activate the roadmap in the 16 high-burden, high-volume states and territory beginning in 2017. The March of Dimes will continue to focus on prevention of prematurity by implementing what is known and translating discovery research into new interventions. This is just a summary of where we have been. We started in the early 80s in the mid-9s, 9.4% in 1981. That rose inexorably to 2006 at 12.8%. And when we've been going down, note that the change in color denotes the change from last menstrual period dating to obstetric estimate dating in 2014. But we still have a ways to go to get to that 8.1% goal in 2020 and the 5.5% goal in 2030. But with your help, leveraging the resources, the networks that you all bring here, we feel confident that we will make that difference, we will achieve the goals, and we will have 1.5 million fewer babies will have been born preterm since that peak in 2006 to 2030. So thank you for all of your help in this, and we will now move on to the rest of the panel. So if Dr. Spong and Dr. Driscoll could move to the podium, please. So to talk to us now about the science of preterm birth, please welcome Dr. Catherine Spong, Acting Director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development, National Institutes of Health. Dr. Spong oversees research on pediatric health and development, maternal health, reproductive health, intellectual and developmental disabilities, and rehabilitation medicine. Among her areas of expertise are maternal and child health, emphasizing prematurity, fetal complications, and improving child outcomes. Dr. Spong.
Thank you so much, I really appreciate Dr. House and Dr. McCabe inviting me today to speak with you about a topic that I am absolutely passionate about. I also admire their thought that I could get through the science of preterm birth in 15 minutes. Perhaps I should just sit down. Fortunately, I have no conflicts of interest, so we'll move through that quickly. But I will say that what I'm going to try to do is to cover very, very briefly, and I'm happy to talk during the discussion and elaborate on some points, on the causes and predictors of preterm birth, and then focusing on prevention of preterm birth. We don't have the ability and the time this morning to talk about all of the therapies and interventions we have to optimize the outcome for the baby who is born preterm, and we've done a lot of work in that area as well. And I'll talk just briefly about some ongoing projects that NICHD is doing that may help in the future us to have more information on causes and predictors in the science of preterm birth. So causes and predictors. Lots of different factors that we know are associated with preterm birth. These include social factors, medical history factors, and behavioral factors, things such as low or high maternal age, African American race, low maternal income, low socioeconomic status. Then different medical conditions, including infections, women with prior preterm births, women carrying more than one baby, such as twins or triplets, medical conditions such as hypertension during pregnancy, and of course, many different behavioral things are associated with preterm birth: tobacco and alcohol use, substance abuse, late prenatal care, and stress. This is a nice study that was done many years ago now, though it seems like yesterday to me, which showed that your history really helps understand what your risk is of preterm birth. And of course, that doesn't help the woman who in their first pregnancy, because she doesn't have a history. But if she's had prior preterm birth, she's at higher risk. And if she's had prior term birth, she's at lower risk. And then depending on the proximate delivery, if the proximate delivery was preterm, that risk is higher than if the proximate delivery was term. We know that preterm birth is a significant risk factor for subsequent preterm birth, and that there is a disparity where there is a higher risk in women of African American or Black race. We also know that the timing of that delivery, if that delivery was very early, say at 24 weeks or 26 weeks, the risk is higher, again, of another preterm delivery. And this has been shown through a number of different studies in a number of different populations. As was elegantly described in a conference that we held many years ago, preterm birth and the socioeconomic and the disparities include all kinds of disparities that we see in other aspects of perinatal medicine, where we see higher rates of preterm birth in women, in African American women. We also see higher rates of stillbirth and higher rates of sudden infant death syndrome. And all of these three areas all have disparities. We know a number of things that we can now look at to help us try to understand, is someone at higher risk for preterm birth? It used to be you could just take a history and from that kind of determine what's her risk. But now, in fact, we have things we can measure. One of those was shown by Jay Imes and colleagues, a really nice study looking at cervical length and showing that the risk of preterm birth is higher if your cervical length is shorter in that early second trimester. We've also identified a number of different biomarkers that you can measure in cervical vaginal fluid, such as fetal fibronectin, proteomic studies, genomic studies, and we've tried to compile them into combinations of different markers and different models to say, is there a way that we can help to predict which woman is really going to deliver preterm? So it's been nice over the last 2 decades that we have advanced from simply asking a patient what her history is to now being able to measure things and to evaluate what her risk is. And even perhaps nicer is that we also have some interventions. When I started training, and I knew that someone was at high risk for preterm birth because perhaps some of her risk factors, I would say, you know, Mrs. Smith, you're at very high risk for preterm birth. You've had 2 prior preterm births. Perhaps you're smoking now. Perhaps you're carrying twins. And she'd say, yes, I know. And what are you going to do about it? And I would say, well, I'm just going to worry because I didn't have anything to offer her. So I'm happy to say that we now have some things that we can offer. We've come a long way. One of those things was just mentioned by Dr. McCabe, and that is progesterone therapy. Both De Fonseca and Meese papers came out in 2003 showing that progesterone therapy can reduce the risk of delivering preterm by about 1/3 in women who are high risk. And both of those studies were focusing on women with prior spontaneous preterm births. In this Cochrane meta-analysis, again showing that a number of different studies looking at progesterone therapy in these high-risk women, finding that progesterone was associated with benefits in infant health for women at risk of preterm birth, either due to a prior preterm birth or to a shortened cervix. Because of those studies, we've identified other areas that we wanted to study progestins as well. So we've looked at women with prior preterm births. We've also looked at women with multifetal gestations, a number of different studies looking at women with twins and triplets, and unfortunately found that progesterone therapy was not beneficial in reducing preterm birth in that population. And then we've also looked at women with a shortened cervix and have found some conflicting studies, some showing that in fact progesterone therapy was beneficial. Predominantly in those studies, there were also women had a risk of prior spontaneous preterm birth. In the Grobman study, which looked at women with a shortened cervix, they in fact found that progesterone therapy was not beneficial, but those were women in their first pregnancy, had no other risk factors for that of preterm birth. Joanne Petrini, through the March of Dimes, did a wonderful study showing the impact then of progesterone, demonstrating that 10,000 preterm births could have been prevented in 2002 if all eligible pregnant women had been given progesterone therapy. Another intervention that has been studied and found to be beneficial in specific populations is the use of cerclage, where cerclage, or closing up the cervix because the cervix isn't working well, is incompetent perhaps, reduced the rate of preterm birth in women with a prior spontaneous preterm birth and a shortened cervical length, less than 15 millimeters. They also found that periviable birth and perinatal mortality were reduced when the cervical length was less than 2.5 centimeters. Suggesting that with specific criteria, singleton, prior spontaneous preterm birth less than 34 weeks, and a shortened cervical length, that cerclage may be beneficial in reducing the risk of a preterm delivery. Other things that have been studied include pessaries. The Arabin pessary was shown to reduce preterm birth in an open-label study of women with a shortened cervix. In a subsequent study of women with twins, the pessary was not found to be successful. However, there are ongoing studies, and I'll give an example of that at the end. So a potential area of future work for us. Low-dose aspirin has also been shown and is clearly recommended by the U.S. Preventative Services Task Force for women to try to reduce the rates of preeclampsia, and it's also been shown in specific subgroups of women, such as women who have chronic hypertension, women with prior history of preeclampsia, there's a whole list of them, that low-dose aspirin will also reduce the rates of preterm delivery. Now, how about the low-hanging fruit, the areas where we really felt you could make a big impact? But although it's low-hanging fruit, it's perhaps the hardest because it's behavioral change. And that was to reduce elective deliveries, reduce those deliveries that are being delivered early, preterm, or in the early term period, that were being done solely electively, not for a medical or an obstetrical reason. And there was a number of studies coming out that showed, in fact, we really needed to wait, as long as everything was healthy for mom and baby, to 39 or 40 weeks, that morbidity and mortality rates were higher if you delivered earlier. This is a lovely study that Brian Oshiro did showing that, in fact, you could impact this behavior change and you could significantly reduce elective early-term deliveries by using specific behavioral changes, where they were able to decrease the elective early-term deliveries from almost 28% to about 5%, an 83% decline in 1 year. Behavioral change is hard, but it is quite doable. At NICHD, we have the National Child and Maternal Health Education Program, which a number of professional societies and organizations work with us to try to bring together and disseminate information. The first topic that this group undertook was that of late preterm birth and reducing elective deliveries before 39 weeks. We launched the Is It Worth It initiative to reduce elective deliveries before 39 weeks, creating different videos and vignettes and a continuing education course. And I also want to highlight a couple of studies that, in fact, were done that did not find benefit. But sometimes those studies are as important, if not more important, than studies we do find an intervention, because by doing those, we can show that something we are doing currently is not necessary. One of those was the what we call the BV and TV trials, the bacterial vaginosis and trichomonas vaginalis studies. These were trials that were undertaken to look at if women who were asymptomatic with either BV or TV, if we identified them and then treated them, could we in fact reduce rates of preterm birth, because we know that these conditions are associated with preterm birth. And what we found was that in asymptomatic women, if you routinely screen them all and then treat those who are positive, it does not reduce preterm birth. And in fact, in those with trichomonas, you increase the rates of preterm birth. So routine screening for these two conditions in asymptomatic women is not recommended. Another example of a study that was not found to be beneficial was that of home uterine activity monitoring. When I was a resident, now I will show my age, home uterine activity monitoring was very commonly done. Many women went home with this. This was a huge undertaking. It was difficult for families, required a lot of equipment, it required a lot of interaction with the companies. And what a number of studies showed was that monitoring uterine contractions at home did not predict who would deliver preterm. So this practice has gone out of style and is no longer recommended. I do want to spend a couple of minutes as we talk about the importance of preventing preterm birth, that we shouldn't let the pendulum swing too far. Oftentimes, especially as an obstetrician, we identify something and we grab onto it and we want to just implement that. And yet sometimes what we're trying to do is not always the best thing. Preterm birth, certainly I want to prevent 100% if I could. But in some situations, preterm birth is not all bad. Preterm birth can prevent fetal death and exposure of the fetus to a hostile intrauterine environment. It can also sometimes be the best outcome for the mother. In some specific conditions, and I'll give just a couple of examples, placenta previa, multifetal gestation, preterm birth or early term birth is optimal for the mother, for the baby, or both, because of those maternal and or fetal risks with the continued pregnancy. So until we can prevent all of these conditions that are associated with complications for mom and baby, we cannot eradicate preterm birth. We had a conference on indicated preterm birth and tried to identify which are these conditions and when should they be delivered. And I think it's just important for us as we move forward to recognize that in some situations, preterm birth is the best outcome for mom and for baby. Now, as we look at the impact of prevention therapies, what we have to date and what I've highlighted, although it certainly has made an impact, is not going to get us to the point that we want to reach. There is only the potential for modest reductions in preterm birth, even implementing all of the known interventions we have to date. This was a nice study that was published by Hannah Chang and colleagues in Lancet a couple of years ago, looking at, in the United States, all of the factors that have been contributing to the rise in preterm birth. And so along the x-axis, you can see some of those factors, such as maternal age and race, ART, and non-fertility, infertility-related multiples. And when you take, say, 5 of those and try to eradicate them, prevent them, have age no longer be a risk factor, in fact, you can only impact the preterm birth rate by about 5%. And importantly, across different countries, so the US is in the middle panel and Sweden is in the bottom panel, you can see that that impact is very, very different from the different factors. So the first one, which is the largest one for the United States, is reducing non-indicated cesarean deliveries. And in fact, in Sweden, that's not very common. So as we look across prematurity prevention, we have some predictors, we have some preventative therapies, and I haven't even spoken about all of the impacts that we have to try to improve the outcome. But I want to leave you with the thought that much work needs to be done. The implementation of the known interventions that we have is not going to get us where we want to go. So where will we go and how will we get there? Let me just highlight a couple of projects. One is, I mentioned before, the Prospect trial in the MFMU network, progesterone therapy and a pessary for women with a shortened cervix with twins. The Human Placenta Project, understanding human placental development and function in real time. If we can understand how the human placenta develops and functions, perhaps we can do some interventions and optimize the outcome for that baby. We're also launching PregSource, a crowdsourcing to understand normal pregnancy. This will be an interactive mobile app to detail the natural history and variations of normal pregnancy by women themselves while they are pregnant. So in summary, we have a number of identifiable risk factors and markers for preterm birth. Research has identified preventative therapies as well as some ineffective therapies. And we've identified different prevention strategies that need to be tailored to the population. And we need to facilitate research and advances for prevention, identification, and treatment. And fortunately, perhaps for all of us, we will still have jobs for the next many years because much work remains to be done. The prevention of preterm birth not only will improve pregnancy outcome and outcome for the families, but it's going to result in healthier babies. It's going to improve the health of the nation and the world. We will have less heart disease, diabetes, and perhaps even cancer as these children grow. Thank you very much.
Thank you, Dr. Spong. We're going to take questions as a panel Q&A at the end. Next, Dr. Deborah Driscoll will lead us in Search of Answers, the Value of Transdisciplinary Research. Dr. Driscoll is the Luigi Mastriani Jr. Professor and Chair of the Department of Obstetrics and Gynecology at the Perelman School of Medicine at the University of Pennsylvania and the Director of the Center for Research on Reproduction and Women's Health. She also is the Principal Investigator of the NICHD Women's Reproductive Health Research Career Development Award and the March of Dimes Prematurity Research Center at the University of Pennsylvania. Dr. Driscoll.
Well, good morning, and I want to thank Dr. McCabe, Dr. House, and the March of Dimes for the opportunity to participate in this panel discussion and really represent all of my colleagues in the prematurity research centers across the country. My goal this morning is to provide you with an overview of the work that's being done in these centers and to provide you with an example that I hope will illustrate to you the value of taking a transdisciplinary approach to finding the causes and pathogenesis of preterm birth. I'm assuming it's the green arrow.
Yes.
So the NIH and the March of Dimes and other foundations have been funding individual investigators working on prematurity research for years. But it was really a wake-up call in 2006 when the Institute of Medicine published this report on preterm birth. And the IOM recommended that we really begin to think differently in our approach to address this very complex problem, and that we take a multidisciplinary approach. They listed 3 priority areas. 1 was the establishment of multidisciplinary research centers. 2 was to improve research in 3 areas. 1, to better define the problem and collect data, meaningful data, and I must congratulate the March of Dimes on this. I think they've done an outstanding job, and I don't always like the results on my report card, but I do like getting it. That we should focus on both clinical and health service research and investigations to understand the etiology and epidemiology of preterm birth, and also focus on public policy. The Institute of Medicine recommended that the National Institute of Health and private foundations should establish integrated multidisciplinary research centers with really 4 criteria. 1, that they should focus on basic translational and clinical research. 2, that it would take sustained intellectual leadership, that these programs should include mentored research training so that we develop a pipeline of junior faculty and fellows and students that will continue this work into the next decade, and that there is ample and sustained funding. And believe me, the March of Dimes has made a tremendous investment in these programs. So the March of Dimes developed a very innovative and strategic approach to address the problem of preterm birth. It really indicates that we have a new paradigm in research on preterm birth. The March of Dimes, instead of sitting there and waiting for individual investigators to send them a proposal about a research project, they did the reverse. They went out and they actively sought investigators and teams of investigators across the country that had the expertise and would bring a fresh perspective to this complex problem. They knew that if we were going to have to solve this, we needed a different approach. They wanted to establish academic partnerships with research institutions across the country that had the ability to foster transdisciplinary research and had the resources to invest in it. They wanted to leverage the strength and the resources at each institution, and we have also made an investment. Each of the 5 centers that you're going to hear about has each committed to making a financial and resource investment in this program, and then they wanted to create a network of centers across the country that could share their resources, data, expertise, and intellectual capital that would interact on a routine basis, either through the web or face-to-face meetings, to advance research on preterm birth. So what is transdisciplinary research? Well, this is a quote from David Stevenson's paper. David is a coordinating PI at the center at Stanford. Transdisciplinary research is purposeful facilitation of intense disciplinary interaction and a sustained focus on solving complex health problems in the real world. This is a map that shows you the location of the 5 centers. The first was established 4 years ago at Stanford. The second was the Ohio Collaborative. We're very fortunate to have Steve Gabby and Jay Imes in the audience, and they've both been involved in this. It involves University of Cincinnati, Case Western, and Ohio State. That center was established 2 years ago, and exactly a year ago today, the center at the University of Pennsylvania with collaborators at Columbia and the University of Pittsburgh was established, and the 4th center at Washington University, St. Louis. Just this year, the 5th center at University of Chicago with collaborators at Duke and Northwestern was founded. So when I talked about the strategy, the March of Dimes kind of went into the back room, sat down, looked at all the research that was being done on prematurity, and said, where are the gaps in knowledge? What do we need to turn our attention to if we're going to solve this problem? And they identified 6 major thematic areas. And I've listed them on the slide for you. And when I show you what each of the centers is doing, you'll see that they are addressing each of these themes. But they went one step further. They also took each theme and they developed a list of sub-themes. They basically laid out a roadmap for us. And as you look at this slide, you'll see not only the different areas that we need to cover, but they went ahead and they assigned those to centers. The black dots represent the fact that that is a primary research program at that center, while the smaller ones are involved in collaborating with centers that are primarily focused on that problem. Here's just a second example called Energy in the Mitochondria, and you'll see a lot of this work is being done at the University of Pennsylvania, and it involves teams with expertise in metabolism, mitochondrial genetics, neonatology, and anthropology. So those are the transdisciplinary implies that we are crossing disciplines, bringing investigators that never thought about preterm birth before. And in fact, in this case, there really was no data on the impact of mitochondrial genetics or the role that it plays in preterm birth. And that's where they were willing to take a risk. They relied on the fact that we had experts in these areas that had shown that they could do this work in other organ systems, in other diseases, but now we're asking them to apply it to preterm birth. There's also collaboration across these centers. This is a busy slide, but it just tries to show you some of the connections. And I'm going to use cervical remodeling as an example of how we are using this new research approach. But first, I just want to introduce you to each of the centers, and I'm sure that in subsequent years, you will hear from different PIs and hopefully hear the exciting work that they're doing to advance research in this area. David Stevenson is the principal investigator at the Stanford Center. They are primarily focused on using bioinformatics to study gene-environment interactions and how those impact preterm birth. For example, does pollution cause preterm birth, or is it associated with preterm birth? What about obesity? They're also studying the microbiome, looking at infection and inflammation in the cervicovaginal space. We're also studying the gut microbiome. They're studying the transcriptome. In the Ohio Collaborative, which is led by Dr. Moglia, he's a professor of pediatrics, they have a number of themes. One is looking at the evolutionary synthesis of human pregnancy. Imagine just how we've changed from evolved from ape to human, and how the human pelvis has changed shape, and how the fetal head has gotten larger, and how does this impact delivery and preterm delivery. They're studying the genetics of unique human populations, some of whom go post-dates. They don't deliver preterm. What's different about those patients? They're looking at the molecular developmental biology of pregnancy. They're studying progesterone signaling in maintaining pregnancy, but also its role in preterm birth, and studying the sociobiology of racial disparities in preterm birth. We know that there are disparities. You've seen the statistics. We need to understand both the biological factors as well as the social disparities and how those two interact to result in preterm birth. At Washington University in St. Louis, Dr. George McCones, a well-known perinatologist and obstetrician and chair of the department there, is the principal investigator. They have 3 research themes. One is using and is developing a new technique for imaging the cervix. They're also working with teams of engineers and cardiologists to see if they can adapt what we've typically used to study the heart and do an EKG. How can we use that technology to study the electrophysiology of the uterus? They're also studying the influence of chronodisruption on the risk of preterm birth, really sleep studies, and how does that influence it. At the University of Pennsylvania, where I have the privilege to serve as the principal investigator, we have 3 major themes. One is focused on bioenergetics, metabolism, and genetics. We're looking at both epigenetic changes in the reproductive tissue, the placenta, the cervix, as well as studying mitochondrial genetics. Abnormal cervical remodeling, which I'll speak to in a minute, and then we're also studying the placenta, as Dr. Spong mentioned. This is an organ that is often overlooked. We know it plays a critical role in pregnancy, in nourishing the fetus, in removing waste, but could it play a role in preterm birth? And the last and fifth center is at the University of Chicago, led by Carol Ober, who is a professor of genetics, obstetrics, and gynecology, and chair of the Department of Human Genetics. And their focus, as one might imagine, is heavily into genetics. And they'll be looking at the regulatory gene expression, regulatory aspects in the reproductive tissues and cells. They'll also be working with us and the Ohio Collaborative to study regulatory variation, transcription, and epigenetic changes. And now I want to talk about cervical remodeling. It's just one example that I think highlights how transdisciplinary research can work in the real world. So the cervix is a dynamic organ. Imagine that it's probably a little bit smaller, or about the size of my fist. And we know that it goes through tremendous changes during pregnancy to allow for delivery. It has to soften, it has to shorten, it has to dilate, so it almost virtually disappears to allow for delivery of the fetus, and then it goes back to its normal shape. We don't know very much about the cervix, but we do know that it contains collagen and an extrafibrillar matrix that's very similar to tendons. So could we apply what they're studying in tendons to the study of the cervix? And that's exactly what we're going to do at the University of Pennsylvania. We want to understand how the cervix is remodeling, but in order to do that, we have to understand the biomechanical properties of the cervix. And then we have to understand how factors like the microbiome, or changes in gene expression, or changes in the immune response can trigger preterm birth. To do that, we're taking a transdisciplinary approach. We have a team of engineers, microbiologists, geneticists, obstetricians, pediatricians, bioinformaticians, and they've gotten together and using their different tools to study this problem. And we'll be studying cervical remodeling at all of these sites that I've listed here. Just to give you an example, Dr. Soslowski, who directs the Musculoskeletal Institute at the University of Pennsylvania, is a bioengineer in the Department of Orthopedics. And he is studying the biomechanical properties of the cervix. In the bottom panel, you saw both the non-pregnant and pregnant cervix. And we're beginning these studies by looking at the animal model. We'll take what we learn in the animal model and then apply it to the human. So we take dissections of the cervix at different gestational ages in the mouse and compare it to the non-pregnant. We have a very fancy apparatus there to do that. And then we can look at things like load. We can look at stiffness of the cervix. And if you look in the right-hand panel, you'll see that the cervix becomes much less stiff about mid-gestation and stays that way. And yet, even though it's not as stiff, we're not seeing preterm birth. So we're using these studies to really understand the biomechanics. But what we still don't know is what triggers preterm birth. Could it be the cervical vaginal microbiome? Well, there are conflicting studies right now. At Stanford, they've shown that there's a lactobacillus poor community state type, which is really just talking about the flora in the vagina, and they've shown that that is associated with preterm birth. But their study was very small sample size, and in contrast, at Penn, we actually found that a different community state type is associated with preterm birth in our population. But what we know is that our population in Philadelphia doesn't look like Palo Alto. There are incredible geographic and racial differences, and that's the value of transdisciplinary research and the value of conducting this type of research in more than one center. And then we can learn from each other, and we can use each other to validate this work. We also are using animal models and creating what we call a dysbiotic mouse. And then we can study that mouse and understand how that environment is affecting the cervical epithelium and the biomechanical properties of the cervix. Because while we may know there's an association, what we really don't know is how does it happen. And that's going to be important if we're going to develop more effective preventative strategies for preterm birth. We also are leveraging grants that the NIH has provided to some of our investigators. This is just one study, Motherhood and Microbiome, but that's also the beauty of these centers, is we don't just rely on funding from the March of Dimes, but we can leverage our other resources and work as partners with NIH. And lastly, I just want to end with, this is a very novel idea. Dr. Spong talked about measuring cervical length. Well, today, we can use an ultrasound to do that, but we know that it's not very sensitive. We also know that there are women that will not have a short cervix at 20 weeks that will go on to deliver preterm. We know that in many cases we'll do an ultrasound and we'll already see the changes. So the tool is not sensitive enough. And at WashU, they're working on developing this new imaging device that may allow us to learn more about cervical remodeling and ultimately be a better tool to predict preterm birth. I hope that this has given you a sense of how we've brought together such diverse investigators to address a very important problem. And I really want to thank and acknowledge this innovative approach that the March of Dimes is funding to really a new type of team science, bringing together really an unprecedented array of scientists who can examine, identify, and hopefully in the future prevent the causes of preterm birth. Thank you very much.
Thank you very much, Dr. Driscoll. And now we have time for Q&A. Please go to the microphones in the aisles, and then please identify yourself, your name, and your affiliation. And I'll just note, I guess we're not recording the Q&A, but we are recording the rest of the conference, and it will be available at the Clinical Directors Network. Please.
Jay Imes, Ohio State. Thank you for a great morning. I have one question for all of you. When are we going to look at the worst cases of preterm parturition, those that occur in the early part of the second trimester? It's sort of a don't go there zone. Before 20 weeks, we don't study those patients who have short cervix progressing at a rapid. We treat them like they're something else. There's a huge overlap, and a lot of the worst cases of premature birth, I think, are happening at a time in pregnancy when we are hands off. When is someone going to knock on that door?
So Jay, that's a great question, and certainly you've done seminal work in a lot of our understanding of preterm birth, and I want to acknowledge that. And I don't think that it's a hands-off area at all. We certainly encourage any investigator, yourself included, to put in an application to study that population. And I would say that in a number of the studies that we do, we certainly do stratify by gestational age. Have we had an intervention study specifically targeted to that population? Not at the present, but it doesn't preclude it. There is nothing saying that population should not be targeted.
Thank you. I would just make the point that we are beginning now, thanks to Marion McDormand, to begin to look at the data, just descriptive data about that population.
Absolutely.
We need more of that to begin any intelligent investigation.
Agreed. Thank you.
So Dr. Imes, I think that we will be well positioned to do that, to stratify by gestational age. So as part of our center, and several of the centers are doing this, we collect samples. We are enrolling women prospectively and collecting samples beginning in the early second trimester. We collected at least 3 time points. And I think that that, again, will allow us to stratify the research. We agree with you. That is a group that we definitely need to target. And the causes may be different. And so it's probably going to be in our best interest not to lump everybody that delivers before 37 weeks when we do these studies. But we're currently enrolling 1,500 women in a study, and we'll have very good phenotyping as well as all kinds of samples, cervical vaginal swabs, tissue that we can use for both RNA and genetic studies. We'll have their placenta, cord blood, maternal blood. And so I think that will be a very rich biobank from which many investigators can study very early preterm birth.
And just to add to that, I mean, there are a number of other studies. The New Mom to Be study, which many of you are well aware of, 10,000 women in their first pregnancy, again, very well documented with samples throughout pregnancy that could be utilized addressing that specific cohort. And then the PASS network, which is another 10,000 women, predominantly in Cape Town, South Africa, and in the Northern Plains. Again, 10,000 pregnancies, well characterized across gestations.
And I think your question also allows me to fill out the point that we really need to do discovery research and then translate it into practice. We've gotten most of where we've gotten so far just by behavioral change, not having early elective C-section and induction. And other behaviors. So we really need to understand the biology and learn to intervene in that biology. And the micropremies are a place, a group of patients where we can have a huge impact if we can learn more about why women go into labor early. Yes, please.
Good morning. Thanks to all the presenters for a very informative morning. My name is Dan Frayne. I'm a family physician from Asheville, North Carolina, and a member of the National Preconception Healthcare Initiative. So my question for all of you is, it seems like it's an exciting time for advancement of science of preterm birth. All of your initiatives focus during pregnancy. And I'm wondering, is there any national conversation or plans for furthering the advancement of the science around preconception health risk factors and understanding how modifying those risk factors will improve preterm birth outcomes?
Kathy?
Yes, and good to see you, and great question. Preconception care before pregnancy, care before someone even knows that they're thinking about becoming pregnant, right? Just good health care prior to pregnancy certainly is an important target, and one that many of us have advocated, that by optimizing a woman's health, optimizing her medical health as well as her nutrition, exercise, etc., should result in a better pregnancy outcome. As you can imagine, the study designs to try to prove that are a bit daunting, but it certainly is an important question to answer. I know that the CDC, when Hania Trash was there, had a large interest in looking at preconception care, and I bet they still do. And they had a working group that a number of NIH staff were also on and trying to advocate for improving preconception care. I don't know of a study right now ongoing to address the question specifically.
But I think one of the things that I'm often interviewed in my role as Chief Medical Officer at the March of Dimes, and one of the things I keep trying to make the point of to the media, is 50% of pregnancies are unplanned in the U.S. One of the first things we need to do is have women begin to plan for when they want to be pregnant and when they don't want to be pregnant. And to your point about preconception care, then it's important to talk to their provider and be ready for conception as part of that plan. Thank you. Yes, please.
Good morning. Great presentations from both Deborah and Kathy. I'm Washington Hill from the warm state of Florida with the Department of Health. My interest and concern is the disparity that we've all seen when we show the slides where the African Americans have the higher rate and other races have the lower rate. Kathy and Debbie, you both alluded to that in your presentations. I'd like to hear what you think are perhaps the causes, and I know you don't know them, but at least what direction are we going in trying to determine from clinical research or other research on the disparity rate?
Who wants to go first?
So I couldn't agree with you more, and it's a real challenge in the city of Philadelphia. And we're trying to address that by collecting information from these patients on social factors, stress, nutrition, housing, all of that information in hopes that we can start to correlate that with the other information we're collecting and studying related to the microbiome and genetic changes. It's really a complex issue, and I think it's going to be our biggest challenge. But I do think having these centers across the country allows us the opportunity to really look at differences in populations and start to address that. So I think it may be the marrying the biologic information that we find with social disparities will probably be the biggest challenge that we face to solve this problem.
You alluded to that when you said the populations in Stanford and Palo Alto are certainly different than those in Philadelphia.
Yes, so if you look at the study that was done on the microbiome, their population is predominantly Caucasian, and in Philadelphia, 70 to 80% of our patients are African American. So we anticipate that we will find differences among those, between the two centers. And I think that's very valid and will be an important part of the work that we're doing. But I think, we also are, reaching out and enrolling these patients in our programs and in our studies. And they're very excited to participate. We have very high enrollment rates. So I think that's also a very good sign for the future.
I think this is one area where we need to go beyond medical factors to better understand what is causing this disparity in outcome. And as I alluded to, it's not just in preterm birth, but it's in many, many medical conditions. If we just look in perinatal conditions, it's in stillbirth, and it's in infant mortality, and it's in sudden infant death syndrome as well. And we need to move beyond that of medicine and look into more societal factors as well, and then to try to identify interventions that can impact that.
Thank you, sir.
And to your point, the March of Dimes Perinatal Data Center developed the Disparities Index around preterm birth, and it's an important part, a new part of the report card this year. But it does allow us to develop a disparity index for each state, and then we can rank the states by their health disparities. So we think it's important that we identify these factors and begin to really rate states on how they're addressing them. Yes, please.
Thanks, Steve Gabby from Ohio State, and I want to follow up on Dr. Hill's question, and I appreciate your answers to his question. And Kathy, you indicated some of these social determinants on one of your first slides, and as Dr. Driscoll will remember, Denise Main and I, back in 1985 at the University of Pennsylvania, tried every possible medical intervention known at that time to reduce preterm birth in our largely African American population. It was approaching 19%, and in a large prospective randomized trial, we were unable to do that. And when I presented our results at a major national meeting, one of the astute observers of our situation in this country stood up and said, "This is a social disease." and I'm not surprised you failed to improve the preterm birth rate. Now, I don't fully agree with that. I think the biologic factors, as you indicated, Deb, have to be married with the social issues. But until we partner with our local, state, and national political leaders to make sure that our pregnant patients have a secure home, a secure supply of food, can live in an area that's not high in crime, have adequate education, and don't smoke, and you could add other social determinants, I think it will be a great challenge for us to overcome our poor situation in terms of our preterm birth rate.
The good news is that just released, I believe last week, was the new report card, and the rate of preterm birth in African Americans in the city of Philadelphia is 13%. So we're making progress. But I do agree, it's really going to take it's going to take a city, a village, to address this problem. You know, I think some of the highest rates we're seeing too are in very rural areas in the South, and that's been you know, it's a challenge. So it's not just urban cities that are facing this problem too.
Thanks. Yeah.
Please.
I know that we have talked about a lot of the scientific evidence, but in the multidisciplinary approach that you're talking about, what focuses there on stress and its impact on preterm births?
There's some evidence that suggests that stress plays an important role, and one of our investigators at Penn, Dr. Neil Epperson and Tracy Bale, with funding from NIH, are actually studying how early adverse outcomes may impact the risk for preterm birth, and they are looking at stress. We're also collecting data on stress in the patients that are enrolled in our study, because it is important factor, and we're going to have to understand how it affects the rate of preterm birth.
And I think the important thing to realize is it's difficult to quantify stress, and it's difficult to actualize that and to make it into something that we can study. The NICHD funded a study called the Community Child Health Network, CCHN, which was really looking at a partnership with the community to try to understand preterm birth and interventions, and had a large focus on the role of stress, the role of resilience, and the role of fathers in prevention of preterm birth. So I think these are really important but very difficult areas to study, and requires us to take a step back from how we typically do a study, and recognize that we need to look, as I mentioned earlier, beyond that of medicine in understanding the importance of stress in pregnancy.
But just as we have had to educate doctors in terms of 39 weeks and the importance of 39 weeks, are we reaching the professionals that are dealing with stress to help them to know about its impact on prematurity?
I absolutely agree with you, and not only that, but also the communities ourselves, and what stress drives, what impact of stress is on the individual and on the community that individual lives in.
Yes, please.
Do the racial differences affecting preterm birth occur in other first world countries? For instance, France, which has a large population of African American women. Do you see the same differences?
I'll start that off, because I've been very impressed by the Intergrowth 21st study. And I actually have used that study to argue that we use diversity as an excuse for poor outcomes in this country. If you actually look at the Intergrowth 21st study, which looked at women in sub-Saharan Africa, now these are all women of high means, no pre-existing conditions, and excellent access to prenatal care. If you look at women there from South Asia, from the northwest of the US, and other places, they all come out with a preterm birth rate of about 4.5 to 5.5%. So if we provide access to care, if we take care of people's chronic conditions, if we deal with the issues about stress that have been discussed, then women who we would say in our society would not have good outcomes do have good outcomes. So I think we can't use genetics as the excuse. I think we might use epigenetics because stress could be translated into epigenetic changes. But that's because of the stress, not because of the underlying genetics. So I think that really aiming for the 5.5%, we need to do it across all populations in this country uniformly and stop using diversity as the reason why we're different than Northern Europe. Other comments?
Yeah, I just want to make an interesting note here that we have found, and I don't have the data here to present, and I don't think we've really looked at this systematically, but when we start enrolling patients in studies, actually our rate of preterm birth drops. So there's something about the kind of support or the wraparound care that you receive when you're in a study, extra attention, maybe extra visits, that may play an important role. So we're going to try a pilot study using community health workers that will target